Everyone, let's get started. Welcome to Grand Round Session for Department of Internal Medicine. Today is Thursday, June 13th, 2024. And it's also our last session for this academic year. Just as a gentle reminder, this is a non-CE credit session. Also, I want to remind you that we will be starting as of next week. We'll be on a brief hiatus for the summer, but we will resume in September. So we're looking forward to seeing you then. Today, we have the pleasure of having our end of year presentation by our Department of Internal Medicine Chief Residents, and they include Doctors Tony Coppola, Dr. Ann Forrest, Dr. Sara Kwiatkowski, Dr. Eric Ott, and Dr. Patrick Willard. And we will have introductions by our program director for our residency training for Department of Internal Medicine, Dr. Rebecca Forrest. Thank you.
Thank you, everyone. I'm so excited and honored to introduce our speakers for the last and my personal favorite grand rounds of the academic year. Our chief residents are truly role model physicians, leaders, and educators. They are essential not only to the day-to-day operations and troubleshooting of the program, but integral to upholding our culture, mission, and values of our training program, department, and institution. This year, our chiefs have truly been adored by house staff and faculty in the department. In our annual program survey in response to what are the best parts of our program and what elements of the program contribute to your well-being, the chief residents is one of the most common responses. Tony is the chief resident for quality and safety and is focused on improving the process for acknowledging alerts regarding patient results and messages at the VA, and has mentored the PGY3 class in a project with an aim to decrease nighttime interruptions for patients admitted to the hospital here at VCU. He's a graduate of Lewis Katz School of Medicine at Temple University and will be joining faculty at the VA in Charleston as a hospitalist next year. Ann Forrest, no relation, is our resident chief and has done a huge amount of work in redesigning our inpatient handoff overnight admission. She's a graduate of Edward Via College of Osteopathic Medicine here in Virginia and is staying at VCU for fellowship in endocrinology next year. Sara Kwiatkowski has the hardest last name to pronounce, but maybe I've mastered it by now, is our intern chief and worked hard to increase engagement with program activities and conferences through an incentive-based competition this year. She's a graduate of Campbell University School of Osteopathic Medicine and will be in fellowship training in cardiology at the University of Maryland in July. Eric Ott is our ambulatory chief and has worked hard to revitalize our ambulatory reports through engaging content and efforts to support that early morning conference attendance. He is a graduate of the University of Virginia School of Medicine and will be working at the Central Virginia VA healthcare system here in Richmond in primary care next year. Last but not least, Pat Willard is our conference chief and has spearheaded efforts in bringing a case-based facilitated small group format to our core conferences this year for interns. He's a graduate of Rowan School of Osteopathic Medicine and will start fellowship in hematology and oncology here at VCU in July. Without further ado, please join me in welcoming our chiefs to the podium this afternoon.
Thank you to Dr. Forrest for that kind introduction, and thank you to the Grand Rounds team for inviting us here to speak today. We're so excited to share with you some of the initiatives that we have been working on over the past academic year. I want to start by reviewing our learning objectives for this session. Our goals today are to review the educational innovations and curricular changes that we've implemented to enhance learning and professional development within our residency program, to evaluate changes made to our conferences and conference structures to increase engagement and improve educational quality, to analyze quality improvement and safety initiatives that were implemented over the past year, to identify the wellness programs introduced to support the mental and physical health of our residents, and assess their effectiveness in reducing burnout. And finally, we want to celebrate the significant achievements of the chief resident class and the residency program over the past year. Pat ourselves on the back a little bit. To frame this conversation, I want to start at the beginning of our chief year. We addressed the residents actually around this time last year and shared our goals and values for the year and actually crafted a chief resident mission statement that encompasses a lot of these values. You can see them reproduced on the slide here, and we'll be referencing them throughout the presentation as we go through some of the initiatives that we started this year to support these core values. Now I want to hand it over to Pat Willard to start our conversation about engagement in education as it relates to those core values.
All right. So I'll be focusing mostly on core conference series and the changes we made this year. So in the beginning of my chief year as a core conference chief, we wanted to take a look back at 2022 and 2023 to see what feedback we had for those conferences going forward. And I specifically looked at the intern core conference. Traditionally, these last year were 45-minute lectures where the first two sessions were derived from specialty services, hemonc, GI, cardiology, and 4-week blocks. And most of the time they were PowerPoint-based lectures with we encouraged interactive learning at that time. And so some of the comments you can see here really highlighted the appreciation for both small group active learning exercises, as well as practicality and focusing more on interactive learning compared to just the 45-minute standard presentation. And so what we wanted to do is take a look at this year changing intern core conference and mainly focusing on the adult learning theory. And so 4 components of the adult learning theory includes the involvement. So residents want to be involved in their learning. They want to have a say in what they're learning and how they're going to learn it. Residents want to be using their experiences to help solidify the information that they're going to be learning during core conference. They want to use team-based approach with problem solving and clinical reasoning. A lot of times the reason why we chose internal medicine to begin with. And then applicable. They want to take whatever they learn at core conference and bring it to the bedside right afterwards so that they can use the information that they learned. And so what we came up with was a case-based learning structure that was reflected from the University of Cincinnati, their internal medicine intern academic half-day model. And so I met with those chief residents there, was able to sit in some of their lectures, and then also reference their website called the Silver Fridge, which had a lot of information as well in building cases and how to incorporate this at our program. And so with this model, as well as a huge input from the VCU specialists in internal medicine program leadership, we developed this new structure. So the interns, they start with doing a theory burst. This is going to be 10 minutes of pure content that is used to start getting the information and the interns to start thinking about what conference is going to be, the topic is at hand. So this one was focusing on heart failure, and we talked about diuretic resistance. We then had guide developments where we worked in conjunction with VCU specialists in developing cases that they would read during these small group learning sessions and come up with questions that would stimulate the learning objectives to be seen. And you could see here, we pulled in a lot of information from guideline directed data, as well as evidence-based articles that we were able to pull into these guides to help with teaching. Now, the main time that we spend is in small groups. We split up into 4 small groups in the core conference lecture hall, where they worked with a single internal medicine faculty member the entire year. And so so these small groups are in the same groups every year based on their house cup or their houses, which will be discussed a little bit further. But the facilitators that are there are able to develop a relationship with the residents, and this will help with decreasing the psychological size of the facilitators and also encourage a safe place for learning and questions to happen. We really incorporate interactive learning. So we took, for the example, in this very interesting picture, we had acid base. We were discussing acid base, and instead of just going through question after question after question, which can be kind of a boring process over time, we made it into a challenge where if you got the question right, your team gets 2 cups and you have to build the highest stack cup here to be the winner at the very end. And I will say this is not all 4, only 1 stack remained high at the end of this, and this was Dr. Fernandez's group. I think Matt back there messed up last minute and kind of knocked over his, so they didn't end up winning. So our goal was to get 50% of internal medicine core conference to be this small group learning. And based on how well things went in the beginning of this new development, we were able to overachieve our goal to 83% of the internal medicine based conferences. And so this was really the positive feedback that generated from the interns, from the facilitators, from the specialists to continue building these cases throughout the year. And we were able to come up with a really good library for future intern cases to come. So this all felt really good, but we had to take a look at the feedback. And so when we look at the intern core conference satisfaction from last year, we compared it to what we asked the residents this year. And we saw that intern core conference went from pretty good last year, but overall 100% people felt strongly or agreed that they felt satisfied in the conference material. Some comments that came up, big ones that were noted that they were happy that the changes were being made. It felt energizing. It helped them have a better activity or better teaching style that forced them to be more engaged, as well as my favorite comment, whereas they had several conferences that were able to apply what they learned from core conference to patient care. And that's really the big goal of what we're doing. And so you could see when we asked the question, small group case-based exercise enhanced learning compared to traditional lectures, 92% felt that they strongly agreed with that statement. So for the goals for the new year, we want to focus on making 100% of the small group learning cases for the intern core conference for going forward. And the second would be incorporating interactive learning in a resident core conference, the PGY2 and above. And we want to get 50% of those core conferences for next year. And so what we wanted to demonstrate this year was trial out a pilot of team-based learning approach, similar to what we do for the interns, but focusing more on new guidelines for the residents. And we did this with the geriatrics block, in which Dr. Fernandez was able to help me out with developing this great case. And you could see the overall overwhelming positive feedback that we got, where residents felt it was an effective way to learn, they felt engaged, and they want to incorporate this into next year's conference. And so please email your guidelines to Ramez, who will be taking over from me. And so he can start developing these cases and we can start working on that for next year.
Thank you, Pat. I'm going to spend a little bit of time staying with the topic of engagement in education, but talking more specifically about our report style conferences. So to complement our Tuesday core conferences, we have resident-led report style conferences, the two pillars of which are our ambulatory morning report and our inpatient noon report. So when residents are on ambulatory rotations, they attend ambulatory report where they work through an outpatient case focusing on management, general skills, or physiology. Whereas at inpatient noon report, they usually work through a fresher inpatient case where they focus on differential diagnosis, workup, and management. And another goal of that report is to build comfort with diagnostic uncertainty. These are usually patients on the wards that are being actively worked up. So the challenge when we entered our chief year was that engagement in these report style conferences at the end of last academic year was felt to be low. One of the lenses through which we can look at feedback to those report style conferences is in attendance data, because we take attendance every time our residents come to report. And I reproduced some data on this slide. So as you can see, for the previous 2 academic years, the ambulatory and inpatient morning report attendance, as well as the core conference attendance with overall attendance, is kind of separated there. So you can see that there had been a drop off in conference attendance during the 2022-2023 academic year. And then you can also see in the other chart on the right that there's kind of a steep drop off as we go month to month throughout the year, using ambulatory morning report as an example. And so clearly, not only do we want conference attendance to be improved, but we also want that improvement to be sustainable. So we spent some time early last year looking at some of the factors that might impact resident conference attendance. And this is based on both feedback from the residents as well as some barriers we identified having just gone through the residency program. I sort of broke it down into the logistics of conference. So it might be hard to attend conference due to timing. Dr. Forrest referenced the early ambulatory morning report. Sometimes that was a barrier for our residents. And then conference attendance expectations weren't always clear based on the rotation that the resident was assigned to. There was also some concern that the topics being reviewed at conference were less relevant and they were employing more passive rather than active learning strategies. So with this in mind, we sort of took a from the ground up approach. We revamped our conference attendance policy, adjusted the timing of ambulatory report to hopefully make it a little bit easier for residents to make it, and repeatedly emphasized active learning techniques in our conference preparation. Reproducing these data charts that we just looked at, and then I'll add our data for the 2023-2024 academic year. So I'm pleased to report that we were successful in improving conference attendance pretty much across the board, particularly in ambulatory morning report, which I'm very proud of. And not only was the attendance improved overall, but you can see we were able to sustain higher attendance throughout the entire year. Still a little bit of that drop off that you can observe in the line chart, but overall, really happy with that improvement. And I don't want the focus to just be on attendance, because this matters for a lot of other reasons. First and foremost, the ACGME internal medicine milestones account for keeping up with conference attendance in one of their milestones, one of the professionalism milestones that we rate competency for all of our residents on. And so another chart here, it's a little busy, but basically I've highlighted the professionalism 3 milestone from June 2023 and then 2024. And you can see that the scores improved across the board for all 3 of our PGY classes. So we're very happy about that and improving compliance with that milestone. But as someone who sat through the ambulatory morning reports most days this year, this is not the center of my mind. The center of my mind are the exceptional reports that our residents put together and the active learning strategies that they employed. I want to highlight a few examples here. This was an introduction to interstitial lung disease in the ambulatory setting, a presentation that was put together by one of our second-year residents and actually given to a guest presenter, Dr. Robert Hallowell, who was here presenting grand rounds earlier this year. Dr. Hallowell specifically pulled me aside to tell me how impressed he was by the active learning strategies that were employed in this presentation. Also want to highlight this talk that was given on Bell's palsy that incorporated a lot of interesting discussion about non-pharmacological treatments and questions to help stimulate conversation and active learning. Similar with this one on ambulatory healthcare screenings, as well as this really exceptional report about updates in asthma management. It was given by one of our third years. So this is what I reflect on when I think about this past year, our residents as exceptional educators. I want to point out on the right here, that's our entire second year class attending the PGY2 teaching retreat, where they get 2 full days of coaching and practice with the Stanford teaching framework to prepare them to become leaders in education during their PGY3 year. So really could not be more excited about what they'll accomplish in the coming year. I want to center us again on our chief resident goals and core values. We talked a lot about education as being a central sort of mission for this year, but we're going to transition to talk a little bit about quality improvement and patient safety. Tony.
All right, thank you, Eric. As Dr. Forrest said, I am the chief resident for quality improvement and patient safety. We have a very robust curriculum here at VCU, so I wanted to focus briefly on some of the highlights. And so I'll be talking about safety event reporting, as well as the PGY3 class project and our quality improvement council. So safety event reporting, as most of you know, is very important. For our trainees, it is part of ACGME milestones. The expectation is that residents, fellows, faculty members, and other clinical staff members know their responsibilities in reporting safety events and unsafe conditions at the clinical site, including how to report such events. And so we currently have 2 systems at VCU. We have VCU HealthSafe, and then at the VA, we have the Joint Patient Safety Reporting System. So to assess whether or not our residents know how to put in reports, we included a question in the VCU Internal Medicine Annual Program Survey. And the question was specifically, I know how to report a medical error at VCU and or the VA, with an option for yes or no. And we're happy to see that 90% of our residents that responded reported yes, while only 10% reported that they did not. The data for this year is still in the works, but we're also happy to see that data from July 2022 to June 2023 showed that the Richmond VA had the highest GME physician reporting across the country. Additionally, with our safety event reporting, resident events are leading to measurable change. One significant event this past year, I wanted to give a shout out to Dr. Carolyn Zinn. She's one of our MedPeds PGY4s. And while working on a night shift at the VA, she entered a safety event related to a delay in obtaining timely imaging for a critically ill patient As a direct result of her safety event, it sparked a thorough investigation between internal medicine, pulmonary critical care, and radiology, and it ultimately led to an immediate update in one of the standard operating procedures for obtaining level 1 imaging for critically ill patients. Focusing on the PGY3 class project, as you may recall from our January session, every year the third year residents, as well as the Med-Peds PGY4s and the EMIM PGY5s, they pick a class project that they all pursue during their QI rotation. This year, the class wanted to focus on increasing routine lab collections before midnight. So the main intervention that was employed this year was the development of an Epic lab order that changed the default time from 3 a.m. to 10 p.m., and those were called bedtime labs, and really collaborating with the nursing staff and providing education to the residents on choosing this 2200 lab collection time. This has been implemented now within the North Tower on North 1, North 2, and North 5. So we're happy to see that on North 5, the routine lab collections increased from a baseline of 0% before midnight, has now increased to 74%. And looking at North 1 and North 2, those are house staff medicine teams 3 and 4. Routine lab collections increased from 4% to 69%. And overall, since the beginning of the intervention, we've audited over 2,000 lab collections. And not only are we happy with the improvement, but we're happy to see that this project has been sustainable. Lastly, I just want to talk about our Quality Improvement Council. So this is a quality improvement group, and it's an opportunity for residents to collaborate and pursue QI projects with faculty membership. It's mentorship. It's active here at VCU and VA, and we have 11 active projects. Over 20 residents and 8 faculty are involved. And I want to give a special shout out to Dr. Robert DeGrazia, who's the faculty member for 3 separate projects. So looking at some of our projects, we have, like I said, at the VA and VCU, we have residents working on tobacco use standardization, central location for resources, inpatient diabetes, durable DNR projects. We have the PGY3 class project that we chatted about. We also have the CPRS Viewlers project that I was working on. We have residents working on a MRICU transfer summary. We have residents trying to revamp the diabetes order set at the VA, more diabetes education at VCU, as well as some of our residents working on Epic Chat here at VCU and some standardized documentation. So really want to use this opportunity to put a plug in that our residents are interested in quality improvement and they are looking for mentorship. So we'd really appreciate anybody who's interested kind of reaching out to get involved in the QI Council. All right, switching back to our core values, I'm going to hand it off to Anne, who's going to be talking about some rotation structural changes this past year.
All right, thanks, Tony, for that. So one of my major roles this year was as the resident scheduling chief, and I felt like I really morphed into the resident schedules themselves. So one of our major goals as a program was to take feedback from prior years from the residents and make some focus program changes when it came to rotation structures. So in selecting our specific focus for structure changes, we looked at the following goals up there on the screen. First being to utilize feedback from residents in past surveys to identify the most valuable and most frequently cited changes that were really important to them. And then we also wanted a structure change that would allow for continuous communication with both the program leadership and faculty and residents. That way we could implement the changes with their feedback. And then finally, we wanted to be upfront with the residents that our goal for any change would be to focus on improvement in education, patient care, and wellness. So overall, we wanted these goals just to reflect those tenets of our mission statement as chiefs, to make sure that whatever change we implemented encompassed visibility of leadership, advocacy for the residents, and then transparency of the changes. And then of course, most importantly to the residents, wellness and education moving forward. So based on these goals, the structure change that we chose was our night to day transition. This handoff structure has been referenced many times over the past few years for area of improvement that was very important to the residents, mainly in wellness and education benefits. Here you can see the timeline of changes that we already trialed prior to this year. So the initial starting model in place for many years was that of nighttime residents presenting newly admitted patients from overnight at the start of rounds, which was between 8 and 8:30 a.m. And that was to the daytime attending and the rest of the resident team during the day. Throughout the years, you can see that we tried making multiple changes from different angles, including changing the inpatient report time from 8 a.m. to 12:15, and then also moving morning presentation to the attending to various times, including 7:30 a.m. and then 8 a.m., which was where it was before this year. But based on feedback from the residents, it just didn't seem like any of these models were exactly the right balance for what we wanted. So with all of those models being trialed without a real successful change that persisted throughout the years, it was our goals to look at the characteristics of the change that we wanted that might be most successful. So we started with education, and we do have an established overnight education program with our academic nocturnists, and they do a great job focusing on case presentations with their midnight report, as well as an ultrasound curriculum that they do overnight. So we felt like the night residents were getting a lot of learning, and we wanted to add to that with our goal for transition. So we thought that a handoff structure from night resident to day resident might be a great skill to gain as the residents transition into the workforce, where they might be faced with receiving an overnight patient with limited sign out or just from an overnight nocturnist as well. And then additionally, we considered the importance of teaching senior residents skills on safely taking an admission during a handoff from the night resident while also balancing daytime responsibilities. So next, we wanted to focus on wellness, and the length of time that the night resident was staying in the hospital waiting to present to the attending on rounds was consistently noted as a point of fatigue for some of our residents. And so that's something we definitely wanted to focus on with this change. And then moving on to patient safety, we did recognize that we would likely need some limitations and guidelines for the night to day transition in order to ensure that patient safety. And we continuously told the residents that that was a huge priority for this, as it was for them. And then finally, focusing on resident and faculty feedback. So our hope for any change was to have that open, continuous communication that we talked about in order to slowly incorporate the feedback based on our change. And with that, we knew that it would likely be a slow rollout period in order to consider everything that might need to be tweaked. All right, so with those goals in mind, we created this new night to day transition structure. And this is our initial model, which really has been the backbone for our entire year, with some changes I'll go over in a second. But it was that the daytime resident receives handoff of newly admitted patients from the night resident prior to the start of rounds. And this handoff was to be done at 7 a.m. with the expectation that the daytime resident sees the patient and is responsible for presenting that patient to the attending on rounds. So this pilot was first limited to 2 teams at VCU, and feedback was obtained from the residents and attendings on those teams before we moved forward with anything. Our first round of resident feedback noted difficulty with daytime intern or co-resident workload when the handoff model was done when the senior resident was off. And so this led us to our expanded model with a new expectation that nighttime residents stay to present to the attending on days the senior resident is off. And then this model was slowly expanded by 1 to 2 teams per 2-week block while continuing to assess for feedback. And we did this very slowly and expanded it very slowly, truly per 2-week block, to make sure that we were catching all the things that need to be tweaked and really listening to the feedback of the residents and faculty. Speaking of, our next round of feedback indicated potential concerns with patient safety if a daytime resident's morning workload was really overwhelming. So we thought this was a good opportunity to have our daytime senior residents learn the skill of knowing that right balance of when they felt they couldn't safely take a handoff based on pre-round workload. So with some more final rounds of feedback that I won't go over, this led us to our final model. And that was that our daytime resident receives the handoff of newly admitted patients from the nighttime resident prior to rounds, except on days when that daytime resident is off or is as necessary based on pre-round workload. And that's determined by the daytime resident. So it really gives them that ownership of the team. And then, of course, the expectation was that resident interns were expected to know the new patient information fully, with the resident having seen patients before rounds and presenting that patient to the attending. All right, so in order to assess the impact of this change, I'll go back to our annual program survey that you've seen a lot of data from already. And we asked residents specifically their feedback on our night pilot. I won't go through every single question, but I just wanted to highlight some big themes, which just to orient you, the dark blue is very positive, orange is positive, the gray is no difference, the yellow is negative, and then the light blue is very negative. So as you can see, really overall, very positive results and positive responses. And we asked everything from patient safety, handoff quality, workload, both during the daytime and the nighttime, educational experience, fatigue and wellness, and the amount of sleep that they were able to get. So like I said, overwhelmingly positive in most areas, which was great to see. And there was two that we were really intrigued by, because we expected that the nighttime residents would feel the benefits of this pilot, but we were intrigued to see if all inpatient rotations, meaning the daytime residents, were pleased with it as well, if that was going to be the case, which it looks like, as you can see on these two, the gray being no difference and the yellow being negative, there's not overwhelmingly negative results, and it's mostly positive for the most part. So, and that's compared to our last year's model or years prior model. So we were very encouraged with these results and felt like the residents really wanted this to continue. And so we have. So as of now, our night to day transition is still active. We review the structure frequently and we talk about it quite a bit and make tweaks based on feedback still. But as of now, it has been implemented on all inpatient teams at VCU and at the VA, and hopefully will continue. So with that, I'll reorient us to our goals and values and introduce Sarah to talk about wellness.
Great. Thank you, Anne. So like Anne said, we're going to shift gears now and talk a little bit about wellness. So our chief class started residency in 2020 at a time when social distancing was encouraged. And so it was really important to us to find ways to bring the program back together in this post-pandemic era. And one of the largest initiatives that we started this year to target this was our House Cup program. So residents were randomly assigned to one of 4 houses, which were named after streets in Richmond. And we essentially gamified various aspects of their residency experience. So for example, residents could earn points for things like conference attendance, scholarly activity, participation in program-sponsored events, and other miscellaneous opportunities throughout the year, including fantasy football, which was a big hit among our residents. We offer different incentives throughout the year to increase participation. So at the midpoint of the year, we had a social event for the leading team with food and beverages paid for by the program. At the end of the year, earlier this week, we had a catered meal for the winning team. And then the most coveted prize, the top earner from each house was awarded an additional day off from an inpatient rotation of their choosing, which was covered by one of us, one of the chiefs. So you can see here the standings at the end of the year. I know Dr. Miliagros is still processing his loss, but we can see that Clay was the inaugural House Cup winner. And then I also wanted to recognize the top point earners from each house. In Marshall, we had Jason Pecorella, in Lee, Ty Achterman, in Clay, Jazrina Valor, and in Grace, Nicole Hawkins. So congratulations to those residents. This slide is a bit busy, so just to quickly orient you, this dark blue, this is data from our annual program survey, if you couldn't already guess. The dark blue indicates strong agreement to the question being asked. The orange is agree. The light blue is neutral, the gray is disagree, and the gold is strongly disagree. So the first 3 questions asked about the influence of the House Cup pilot on resident participation in scholarly activity, conference attendance, and involvement in program events. And I think the main takeaway from these first 3 charts is that there are a lot of factors that contribute to resident involvement in these areas, and our residents were already quite productive in these areas, but at least for some of the residents, there was an impact of the House Cup pilot on their involvement in scholarly activity, their attendance at conference, and their participation in program events. And then the big takeaway from this slide is this last chart, which shows that a large proportion of the residency program did vote in favor of continuing the House Cup system. So as I said, this was its inaugural year, and obviously, we can continue to grow, and I'm excited to see where the program leads in the next few years, but there's already been a positive impact up to this point. One of the program events that we started this year was our out of the office hours. So residents were invited to join us at various locations throughout Richmond to spend some time together outside of the hospital. And as an added bonus, they did earn points for their house by attending. So this first picture is at Hardywood. The middle picture is Scoop Ice Cream, and then the last picture is the Vale. Some of our goals this year were also approachability and visibility, and we knew that we wanted to find ways to engage with the residents outside of didactics and retreats. And one of the ways that we did this is through our ground rounds. So we, about once per block, we visited residents in their team rooms, both at MCV and the VA, with our snack and coffee cart. We also had holiday themed ground rounds. There are some pictures here from our Halloween cart, and we even tried to create a Yelp page. Apparently you have to have a real address for that. But we did come up with a pretty good slogan. You might find better coffee, but you won't pay less. So another way we focused on visibility and wellness this year was through our Waffle Wednesdays at the VA and Flapjack Fridays at MCV. 1 to 2 times per month, we would cook breakfast for those residents who were attending ambulatory report that day. We also received feedback from the residents that they wanted more variety and increased frequency of meals at conferences. Dr. Trankel once told us that we have been carrying food every time he's run into us in the hallway. So I think it's safe to say that we've achieved that goal. So these pictures just feature a few of the many different restaurants that we catered from this year. And then here are some more photos. Our VA chiefs even invested in a popcorn machine. And you can see here some of our residents enjoying popcorn at an inpatient report. During the month of February, we featured Black-owned restaurants in Richmond to celebrate Black History Month. So we catered from Mama J's, Buttermilk and Honey, African on Main, and Soul Taco. This was very well received by our interns, so I just wanted to shout out Christina Fernandez for the idea. This year, we also revamped our social media in an effort to target 2 of our goals, education and camaraderie. So we would feature abbreviated versions of some of our inpatient reports for those residents who were unable to attend in person. We offered opportunities to apply knowledge through short quizzes, as well as learning points to solidify concepts learned. And we even had participation from faculty and alumni. We also did end of block shout outs, which is a way for residents and faculty to recognize one another for their achievements over the course of the block. There are just a few examples here, but we have many more saved in a highlight on our page. And so I'm going to use this opportunity to plug our Instagram. And here's a QR code. If you all want to scan and follow, we'd love to have you. Like and subscribe. All right, so more data from our program survey. So each year residents are asked to rate their quality of life. And this year we saw an increase in residents who rated their quality of life as good compared to prior years, and a decrease in those who rated their quality of life as bad. We also asked residents to rate their satisfaction with their work-life balance. And this year we saw an increase in residents who reported feeling satisfied with that balance, and fewer residents who reported feeling dissatisfied. We also saw a decrease in burnout rates over the last 3 years. So obviously a huge accomplishment. So with that, we will pass on the torch to the next group of chiefs. I think you all are probably already familiar, but Virginia Lindley will be taking my place as intern chief. John Stewart will be taking over as resident chief. Ramez Bodair will be taking over as conference chief. Rose Kang will be our ambulatory chief, and Sam Wickman will be our chief resident in quality and safety. And then for the first time, we'd like to announce the chief residents for the 2025-2026 academic year. So please join me in congratulating Madison Nguyen, Rahan Razak, Ty Achterman, Al Hussein Yassin, and Josh Boran as the CRQS. Thank you so much for your attention and your support this year. Any questions?
I have a question. So you mentioned your out of the office hours were hugely successful, and you also implemented in the office hours. Which do you think were better attended? Did you notice a difference?
Nobody came to our in the office hours. First of all, I think West Hospital is a bit of a trek for some people, maybe, but also it's also flooded out. So it's an omen.
Maybe not a concern.
But our out of the office, just because people felt like it was more relaxed and we wanted to be available and visible and much more fun than sitting in our office.
We also had a lot of visitors at the VA. I will say, speak for yourself.
Oh,
West
okay,
Six,
well,
but, a lot of visitors.
That's not a reflection at who was in the office at the time.
I'll just say a comment. You guys are fantastic. It's been a wonderful year having you here. The presentation, you guys did a wonderful job. And, you know, I get to see you guys not as much as some of the other APDs, just being focused on procedural stuff, but it's amazing what you guys have done in such a short period of time. And I don't think you can really imagine how much of an impact this will have in the years to come. And I'll put another plug in for this Instagram account. I follow that like no other social media account on the planet. I'm not very savvy with these things, but it's the first thing I wake up, I'm looking for the new thing, you know. So I'm sure the residents are doing the same thing, and really, I think it's really helped with the camaraderie piece of it. So a lot of those improvements in numbers and wellness are likely probably impacted not only by the things that you guys did, but also the people that you are. So thanks for your time devoted to this discussion.
Thank
Thanks,
you.
Steve. That was very nice.
I want to have a comment and a question. So, first of all, amazing job, and I absolutely love the data-driven approach to everything you've done. It really speaks to what we do in academic medical centers and how we train each other, right? So you should take real personal pride in everything you've done for not just the residents, but for the whole department and institution. Like, we really realize how important the residents are to everything that we do. So the direct patient care, the education, and the research. Then I have a question. How did you manage to move the needle so much on wellness? What do you think was the key? Because I need to do it for the faculty. So you did move the needle. What do you think? And it may be hard to absolutely nail it, but I'd be interested in your personal opinion as to what you thought was the most impactful.
I think the most important thing for our residents is just to feel heard. And so even if we weren't able to take our food from 0 to 100%, or I guess 25 to 100% or whatever it was, just knowing that they were heard and that we were increasing the variety, increasing the frequency, making changes within conferences. I think they just felt validated and that we cared about their residency experience, and we're committed to making it better for them. Then Eric, I think you want to add.
Yeah, I'll echo that by saying the power of even small changes. I mean, I think we all know small changes are hard to make in a program this big, but the fact that we were committed to it, changing the time of ambulatory morning report just to facilitate people getting there on time, and recognizing that it's asking something to come in early on a day when you might not otherwise have to, when you're working so hard on your inpatient rotation. I think just that acknowledgement went a long way. I also want to give a particular shout out to our intern class from this year. They really came in with enthusiasm and engagement, the likes of which I would never have expected. And I think Pat did a huge amount of work with the core conference series. So I would guess, I don't have the data to back this up, that a lot of that improvement in wellness is driven by our interns, who just were so committed and engaged, and really tried to make the most of this year. So I definitely saw that in them.
Any other questions?
Is there any questions online?
Oh, wait. I'll check. I'll look. Oh, no.
Oh,
We might need some technical support.
yeah,
Yeah.
let's re-exit out of this. Oh, we have a chat.
In one chat.
Oh.
Thank you. Thank you, Rose. Thank you all so much for coming.
Can I get a picture of you with your introductory slides? You have it? You got it. Okay, I took back to get you to switch the slide.
Came
Okay.
early.
All right. well,
Thank you all.
And then, yeah, we'll see you all, I guess, on Saturday, right?
That's right.
Yes. Big change that we're
Trying to like facilitate that for a long time, but I think. there's things that happen.
Provided opportunity for these.
Okay.
Yeah.